necessary points. In the left panel, the activated clotting time monitoring system is shown. Blood samples are monitored constantly. Following transeptal access, a single bolus of heparin is administered in vein. 2 blood samples are taken every 15 minutes in order to monitor the activated clotting time, which needs to be between 200 and 250 seconds. While the operator refines the map, the nurse checks for the ACT before ablation starts. When the left atrial geometry is accurately reconstructed, the anatomic marker icon is opened in order to delineate the perimeter of the mitral valve using the red arrow shown on the screen. Next, the valve surface is cut out. The same procedure is then repeated for the transeptal puncture area. At the end of the mapping procedure, smooth maps are obtained thanks to the sequential point acquisition everywhere in the left atrium. The ablation procedure has started. The irrigation rate of the tip catheter is raised from 2 to 17 milliliters per minute. On the bottom left panel, from left to right, impedance, ablation time and tip temperature are shown. These values are constantly monitored. Irrigation rate is titrated to achieve the desired power. Energy output is limited to 40 watts and 48 degrees Celsius throughout the entire ablation procedure. Radiofrequency energy is continuously applied with a gradual catheter dragging in a to and fro fashion over each point for 5 to 10 seconds to keep temperature down. A cumulative time of 15 to 30 seconds of radiofrequency is needed. The end point is a local bipolar voltage reduction by 90% or to less than 0.05 mV. A soft contact is important to avoid volume overestimation and complications. The circumferential PV ablation or CPVA consists of circumferential pulmonary vein lesion lines performing a point-by-point tailored distal disconnection of all pulmonary veins, and additional lines including the mitral isthmus line, posterior lines, and cavotricuspid isthmus are also performed. The circumferential ablation lines can be either guided by 3D electroanatomic mapping, by fluoroscopy, or by intracardiac echocardiography. The radiofrequency applications, shown by the white dots on the NAVX screen, start by performing the mitral isthmus line according to our modified strategy. You can see a point-by-point radiofrequency application starting at the mitral annulus towards the left inferior pulmonary vein. The electrogram shows in the last 2 tracings the potentials recorded by the proximal and distal electrode pairs of the ablation catheter. The NAVX system offers a proximity indicator that, based on the intensity of the color of the tip, allows the operator to monitor the optimal tissue contact of the ablation catheter, which when associated to potential abatement confirms the achievement of the ablation endpoint. The catheter is now moving towards the left superior pulmonary vein, keeping away from the ostium, passing between the left atrial appendage, located anteriorly, and the vein posteriorly. This is a delicate point of the procedure, and it is difficult to obtain complete potential abatements, which may require longer radiofrequency applications. The ridge between the left atrial appendage and the left superior pulmonary vein is a challenging site. In this critical region, there are fragmented electrograms at the ridge, higher impedance and high voltage organized electrograms within the left atrial appendage. If the ridge is narrow, its ablation may result in residual gaps. Potential abatements or double potentials are seen along the lesion lines, confirming the block. The NAVX software allows a detailed anatomy reconstruction of the left atrial appendage and the ridge, as you can see in this lateral projection of the left atrium. The operator returns to the line to check for potentials and apply radiofrequency where needed. The operator is now starting to complete posteriorly the circumferential lesions around the left-sided pulmonary veins. starting from the left inferior pulmonary vein towards the left superior pulmonary vein. The stability of the catheter is obtained by the respiratory compensation function, which may be reset at any time if necessary. Particularly the posterior wall ablation can be painful for the patient, and the pain may cause the respiratory frequency to change. The ablation procedure is accurately followed on the NAVX screen by 3D rotations, which is particularly useful in challenging points such as the ridge. We tailor circumferential lesions according to the single patient's anatomy and physiology if vagal reflexes are elicited, which may vary between different subjects. In some patients, encircled areas can be larger, varying between 20 and 30% of the left atrium, mainly depending on the atrial dimensions, which are usually larger in patients with long-lasting, persistent or permanent atrial fibrillation. When ablating the posterior wall, the occurrence of pain may cause the patient to move and to change his respiratory frequency, leading to catheter instability. In these cases, a new respiratory compensation is required. The respiratory compensation button is pushed and the yellow window appears on the screen, allowing to begin respiratory data collection. Data are being acquired in a few seconds. One of the advantages of the NAVX system is that patient movements during the procedure don't affect the reconstruction of the map, since the reference catheter moves equally to the patches attached to the patient's body. In the posterior region of the atrium, we prefer to deliver repeated radiofrequency applications of short duration instead of a single radiofrequency application of a duration greater than 30 seconds, in order to avoid the risk of cardiac perforation. With the manual standard catheters, cardiac perforation may rarely occur, and atrioesophageal fistula occurred in just one patient out of more than 10,000 undergoing standard CPVA in this center. The operator has completed the circumferential lesion, joining a line from the ridge across the roof around the left superior pulmonary vein. This can be clearly seen by this roof view. Substrate ablation in this region destroys myocardial sleeves. It has been demonstrated that these sleeves are important in maintaining atrial fibrillation. The operator is completing the linear lesion in this important area. This is done in order to reduce the substrate, including the myocardial sleeves, when possible. Unfortunately, sometimes this is not possible because of the anatomical variability of the pulmonary vein insertion. Variants, such as a common ostium or additional pulmonary veins, may be present. This is a very challenging region considering its location between the two pulmonary veins ostia. However, in this case, no difficulties were encountered. When the lesion set is complete, the operator checks all the ablated areas for the completeness of the lesions. Usually, double potentials or no potentials are found. However, further radiofrequency applications are needed within the lesions and on the lesion lines when potentials are still present. The operator first checks for the presence of residual potentials around the left inferior pulmonary vein. In this case, a few potentials are found, requiring a few seconds of radiofrequency application for them to disappear. This is a very important phase of the procedure. It consists of a point-by-point validation of the disconnection and is important for substrate modification. Next, the operator checks the region around the left superior pulmonary vein, where some residual potentials are recorded. Again, radiofrequency energy is applied to abolish them. Potentials are slowly disappearing. Finally, the operator checks for potentials on the line between the left-sided pulmonary veins, refining the lesions with further radiofrequency applications.